Thanks, Gil, for having Tom and I. It's a pleasure for us to talk about the LITESPARK005 quality of life data just published in Lancet Oncology. I'll start and actually talk a little bit about the clinical data. These data were published in New England Journal a little bit ago and have been presented a couple times. This was a trial in refractory kidney cancer, and patients were refractory to both immune and VEGF-targeted therapy, as is common now for kidney cancer in a refractory setting, and were randomized equally to either belzutifan, an oral HIF-alpha inhibitor, transcription factor inhibitor, or everolimus, an oral mTOR inhibitor. There's about 370 patients or so in each arm. And what the high-level clinical data showed was an advantage in both response rate for favoring belzutifan, 23 versus about 5%, and also progression-free survival. The medians were equal at 5.6 months, but the hazard ratio significantly favored belzutifan with a hazard ratio of about 0.75, including a bit of a tail of the curve out to 18 or 24 months. There was not a difference in overall survival for belzutifan. So based on these data, the drug was initially FDA approved, has been starting to be approved around the world, and at least in the US is in common use in clinical practice. And then what was just published was the quality of life results, which kind of support some of the toxicity data. So I'll turn it over to Tom to talk about the quality of life results.
Thank you, Brian. I never thought you were going to ask me, to be honest. So the quality of life data was published recently in Lancet Oncology. And I think it's important because we know many of these patients have been on treatment for a long period of time, and many have chronic VEGF TKI toxicity. And so it's nice to switch away from VEGF TKI therapy. But the question is there a quality of life benefit for belzutifan versus everolimus, which we know is associated with stomatitis and other adverse events? When you look at the adverse event profile for the two drugs, you can see that there is a difference between the two, which is relevant. When you look at the data that we collected, we showed about 90% of patients at baseline explored or filled out the quality of life questionnaire. We looked between baseline and 17 weeks, and about 55% had quality of life questionnaires measured at 17 weeks. We looked at the least square of the mean between baseline and that 17 weeks. We used two methods. We used the FKSI-DRS, disease-related symptom score, and the QLQ30 EORTC score. So we used two methods. And what we showed is the decrease in quality of life was less marked with belzutifan compared to everolimus, suggesting that the belzutifan arm was better tolerated. We went on to look at time to deterioration. So we defined deterioration as a specific drop in quality of life score in the two arms. We didn't show such a big difference between that. But then within the EORTC questionnaire, there are different components, things like physical and emotional components. And again, in there we saw belzutifan outperforming everolimus in specific questions like physical score, for example. I think the overall summary actually complied with the hypothesis that belzutifan, although associated with toxicity like anemia and hypoxia, overall has less toxicity, which is associated with deterioration in quality of life, and therefore is not only efficacious, but well tolerated, reflected by these differences that we've seen in the PRO quality of life data.
And Tom, I might just add to finish up. I think, you and I on our podcast have sometimes been critical of quality of life data, and are the questionnaires really measuring what we think and quantified and things like that. I think what was believable for me is, having given a lot of the drug, is we know it's well tolerated, that the adverse effect profile, is I think more limited than TKIs. There's the anemia and hypoxia you mentioned. I find in my clinical practice, if patients make it through the first couple of weeks and are okay, then it's generally smooth sailing. The anemia time course is a little more protracted, but I think easily manageable with growth factors and such. And so, I think the questionnaires and the data that you cited it fits with the straight toxicity data and my clinical experience that it is a really well tolerated drug.
Yeah, but it doesn't get us away from the fact that when we do quality of life studies versus placebo with drugs associated with 10 or 20% life-changing toxicity, we often see no difference in quality of life. So I actually think that, my opinion is, we still haven't got these quality of life questionnaires right. And the default position is it's hard to show differences between these agents, even when they definitely exist. So just because this one has come home doesn't mean there's nothing wrong with the methods we're using. And indeed, there will be flaws with the methods we're using here as well. And so I'm keen that we continue to explore this important issue. I'd like us to be using wearable devices, getting real-time information from patients. I'd like us to be having specific quality of life questionnaires for specific scenarios. I think the adjuvant setting is very different from the metastatic setting. And I'd like patients to be more involved in real-time data collection rather than saying, how did you feel over the last week while you're picking up your drugs at the hospital, which is what they're doing. And many patients are trying to get out of the hospital as quickly as they possibly can.
I think the data are believable, but there's still a ways to go before we're really truly measuring patient quality of life, right? We call it quality of life, but it's a facsimile thereof, given the limitations of the questionnaires. But nonetheless, good data. Congrats on the publication.
And I hope the quality of your life remains high for the rest of the day.